Yes, so again, a warm welcome to everyone. This is the HIV Masterclass. Today's topic, we are looking at switching patients to second-line ART regimens with a specific focus on NNRTIs as part of our first-line regimen. You would see in the next 2 consecutive weeks, we will deal uniquely with patients on a PI-based regimen presenting with a high viral load. And a follow-up after that will be a patient who presents with a high viral load whilst taking a dolutegravir based regimen. So I'm hoping that it's a build-up, from last week's hectic topic where we dealt with the basics around HIV resistance. I'm going to switch off my video just to allow people not to struggle with network, and we can start. So thanks as well to AbbVie for their support, and we really want to continue to empower, to educate them, to enable health workers to maintain their clinical competence. So again, AbbVie is our sponsor. However, they have no influence in terms of what we teach. We try to make sure that we maintain the highest ethical practices. So you can trust that what I'm going to share with you is based on current evidence, mostly, our local guidelines and so on. So today's topic will focus on the practical approach to a patient who presents failing a first-line regimen, particularly an NNRTI-based regimen, without a lot of complications. And I hope that you will join me as I engage you, because I think it's going to be an interactive session. Feel free to share any questions. Feel free to share any comments. I also want to encourage you to become members of this platform so that we are able to continue to support you, with educational resources as needed. This is a build-up again from where we started. And just to remind you in terms of definitions, that when we talk about acquired drug resistance, we are talking about a patient who has been exposed to ARVs, who later on develops resistance. Usually, most of the time, it's likely to be due to poor adherence, but there's other factors, whether drug interactions, which we fail to pick up, patients experiencing side effects, poor drug absorption, and so on. So this resistance is acquired whilst the patient has already been initiated on ARVs. Transmitted means that someone who's got a resistant bug is transmitting this particular virus to the next person. It can be through sexual contact, but also sometimes mother to child transmission can contribute towards the same. We have a pre-treatment drug resistance, and here the defining point is that at the time when ARVs are started, your patient already has some mutations or some resistance to some of the drugs that we use. And it is this pre-treatment drug resistance that determines the effectiveness of our first-line ART regimen. Hence, sometimes we need to change those regimens. Remember, last week we sort of also agreed that this is sort of inevitable. We do think, theoretically that you can prevent resistance, but in practice, we know it's quite difficult because our HIV program is huge. We have ongoing health systems, challenges, be it availability of drugs, the storage of drugs, the patient-related factors around the self-care and poor adherence, but there's also what the virus brings, because the virus itself, as it replicates, this reverse transcriptase enzyme lacks this error-proofing mechanism, and it makes so many mistakes on a daily basis such that resistance becomes inevitable in our context. Today, we are just discussing patients who are taking a first-line regimen, and I want to remind you, because when we see patients who are on a regimen and they've been failing for 5, 6, 7 years, and I talk to health workers, some say, "Hi, doctor, I have faith that this patient will resuppress." I want to tell you that once a patient presents to you with a detectable viral load, and the patient is taking an NNRTI-based regimen, over 96% of those patients, so for all your 100 patients whom you are going to see in the next few months with a high viral load taking an NNRTI-based, the majority, the virus has already mutated. You know, they've already developed significant mutations, particularly against your NNRTIs, you know, and then your lamivudine, and hopefully sometimes you also get this mutation, your K65R, which would render drugs like tenofovir, abacavir, you know, less effective. So how do you reverse? Are these mutations reversible? Probably not. So sometimes we tell patients, I say, hey, go home, use condoms, you know, it's a bit too late, you know, at that time, you know, and we need to appreciate that if a patient presents with a high viral load on an NNRTI regimen, they are most likely the virus has already mutated, you know, and if you do confirm with your second viral load and it's still high, most likely, you know, you should have a high level of confidence that your patient has failed these particular drugs and therefore needs another regimen. And it is this lack of confidence, health systems issues, lack of mentorship, social issues that make patients, you know, to default and adhere poorly, that they contribute to delays in switching. As you can see, it takes around 59 weeks to switch a patient who presents with a high viral load on first line, which is not acceptable because it means the virus continues to replicate in the presence of these drugs. Our patients would accumulate more and more complex, you know, mutations, which would really affect even some of the second line and third line ART regimens. A high viral load means the CD4 count ultimately starts to drop. Your patient presents with severe or significant opportunistic infections, AIDS-defining conditions leading to morbidity and mortality. So we do not want to smell the virus. We don't want to see any detectable viral load anywhere. What we prefer to do is to really ensure that every patient who is living with HIV is started on ARVs and they are fully suppressed and they are kept alive and healthy. And this is a slide which I shared as well last week, which shows that a high viral load, whether it's one single viral load or two viral loads, are associated with bad clinical outcomes and particularly AIDS-related deaths. So it is not acceptable to have a patient who is HIV positive, who is taking ARVs. It is not acceptable to smell or to detect the virus. We have to deal with this virus and ensure that our patients are fully suppressed. So this is really key. So yeah, so let's go through Mr. George. I think he will help us to understand some of the key practical processes you would need to follow when you are presented with a patient who presents with a high viral load on a first-line regimen, particularly your NNRTIs. So he is 26. He's been on ARVs for 1 year, 1 month. He is taking tenofovir, lamivudine, and efavirenz. He's also on cotrimoxazole. Today, he's clinically okay. He has no problems, but he tells you that, sometimes I forget and I miss some doses there and there. His vitals are okay. You can see the 6-month CD4 count is 250 cells. His viral load at 6 months was suppressed, which was good. But now we are reviewing the 12 months results, and you see that the CD4 count has sort of dropped to 175, and the viral load is no longer suppressed. The viral load is 10,890. So I have a question for you. When you look at this case scenario, what are your suspicions? What do you believe is going on with our patient? You may select more than one option. You may select more than one option. You have 30 seconds, to review and to decide. Then we will see which of these are most likely, less likely, and then we take it from there. All right. I see most of you are engaging. 5 more seconds, and then unfortunately, I will have to interrupt the poll. All right. If you have not voted, it's okay. We shall learn together. These are anonymous. We will never know what you selected. I'm showing you your selections there. So it's a suspicion. You know, when you suspect, you can never be wrong. It's just a suspicion because the question says, what do you suspect? So virological failure, I think we have a merit to think of a possible virological failure because the viral load is no longer suppressed. It is 10,890. Immunological treatment failure, well, you know, the CD4 count has dropped to below the 6 months CD4 count. We unfortunately do not have the baseline CD4 count because remember, immunological treatment failure by definition is when your CD4 count drops to below your pre-treatment level. So we do not have that baseline CD. All we can say for now is that it has dropped below the 6 months, but we don't know what the baseline was. There's clinical failure. So remember, clinical failure happens in a patient who has taken ARVs for at least 6 months and they develop an AIDS-defining condition after taking effective ART for 6 months. So yes, our patient has taken ARVs for more than 6 months, but we do not have any clinical presentation of any stage 4 or even stage 3 condition. So clinical failure unlikely. Poor adherence, yes. Remember your first 100 reasons why someone has a high viral load is that there's adherence issues. He's a male patient, he's still relatively young, and he reports missing several doses over the last few months. So adherence is an issue, and it's possible that some patients might present with all of the above. So I'm going to continue and emphasize some of the things that I was saying. So for now, we are at the suspicion level. We do not have a confirmation of any of these failures. For example, virological treatment failure talks about 2 consecutive viral loads more than 8,000, and these viral loads are taken at least 3 months apart. We're talking non-pregnant adults today, so we're talking 3 months between these 2 viral loads, and there's adherence, you know, given, and this is with a patient who would have taken ARVs for at least 6 months. Immunological treatment failure has 2 actual definitions. The first one is if your CD4 count falls below your baseline or your pre-treatment CD4 count, or you have a persistently CD4 count that is not improving, right? So a failure to increase your CD4 count by around 80 cells in 12 months can be considered immunological treatment failure. And then clinical treatment failure, the development of an AIDS-defining condition after a patient has taken ARVs for at least 6 months. So, you know, we are suspecting virological failure. We don't have a confirmation yet. What is very important, really, it is this particular part that half the time, at the time when we predict using a viral load that it is high, we would have already failed to pick up patients who are at risk of treatment failure because of their missing appointments, the pill counts don't match, you know, they have mental health issues, poor social support, lack of disclosure, you know. So it's quite important that we work more on improving adherence and putting systems in place to support and enhance, you know, our patients' ability to care for themselves. So generally, once a patient presents with a stage 4 condition, it means they would have been failing for a while because first a patient defaults, they have high viral loads, the virus starts to replicate in the presence of the drugs, you get mutations that lead to resistance, the CD4 counts start to drop, and as they drop, your patient can present with some of the AIDS-defining conditions. So this is quite important to note that in South Africa, you know, today the viral load is our key monitoring test or system which is used. We no longer rely on the CD4 count or even the clinical staging for determining treatment success, because by the time these 2 things become an issue, it would have meant that your patient would have been failing for a while. So we really don't want to smell the virus. and we want to keep the virus fully suppressed, which is quite key. Now, all patients, all who are taking ARVs must be monitored. You know, I don't want to talk much about clinical monitoring. I want just to focus on the viral load. That it is a clinical crime. I know there's nothing like that, to have a patient who is taking ARVs and they are not being monitored and viral loads are not being done. And I can tell you, this is a huge challenge in our country to ensure that patients who are on ARVs, once they reach 6 months on ARVs, a viral load must be done. And if it is suppressed, it should be repeated at 12 months. Then if it is suppressed, it should then be taken every year, at least once a year. In the public sector, we don't do baseline viral loads, but I know people who are working with the private healthcare, they also do viral loads before treatment is started. In the public sector, that is not part of the program. But we need to ensure that this monitoring happens. It should happen because the more we monitor our viral loads, at the earliest sign of a high viral load, we need to assess and ensure that we are working with our patients to address any issues that they might have. We do not want to pick our patients when they come back and they are already sick. So this is quite important right there, right? So continuing from there. So now, it's still the same scenario. I have a follow-up question for you. You told me what you are suspecting, but having seen Josh, having seen that he's missing several doses and he's taking an efavirenz-based regimen, tenofovir, lamivudine, efavirenz, is there an indication at this point for switching a regimen? Is there an indication of switching a regimen? Great, I'm giving you a few more seconds. Is there an indication of switching a regimen? I'm so excited to see that you are all participating. So please, let's all get into it. It's part of our learning experience, you know. Yes, I'm going to stop because we only give our polls 30 seconds. If you have not participated, it's okay. So you would see that most of us say no, that's about 74%. And then some of us are saying yes. So if you look at that definition of treatment failure, right, from a virological point of view, you can only talk about a confirmed virological treatment failure if you have 2 consecutive viral loads above 8,000. So here we only have 1 viral load more than 8,000. So we don't have a confirmation. So you are not going to be able to switch to a second line regimen, right? Some people at this point might decide, you know, to start playing with the drugs, and we're going to deal with that shortly. But all in all, let me take you through some theory around what needs to be considered. So firstly, you need to appreciate the definition of this treatment failure. And here we are dealing with non-pregnant adults, that for you to confirm that this patient of mine is truly failing treatment in terms of the guidelines, right? You need at least 2 consecutive viral loads taken 3 months apart, right? And you can only talk about treatment failure in a patient who has taken ARVs for a minimum of 6 months, because before 6 months, you sort of think that they need a little bit of time and support before they can fully suppress. Though with our current regimens, especially the dolutegravir kinds of regimens, by 3 months, most of our patients have already suppressed. So this is quite important as well. So achieving and maintaining viral load suppression, it's a primary, it's not even a first goal, it is the primary goal why we initiate patients on ARVs. It's like HbA1c, you know, in terms of diabetes, or even your blood pressure control in terms of hypertension. If your BP is not monitored and it's not controlled, you can't be happy, you know. So ideally, we want all our patients to have a suppressed viral load, and suppression in the public sector, we talk about a viral load that's less than 50 copies. And if the viral load is rising and it starts to rise above 8,000, you also start to become a little bit more worried. And you can see that there's a gap between 50 and 1,000. That is beyond today's talk. We did have a similar talk last year, and I think we're going to have it again probably in the 3rd week from today or 4th week, where we talk about low-level viremia. So we'll have to do it again. But yeah, we will discuss it at that point in time. So basically, principle number 1, we want to always have a suppressed viral load. Anytime you can smell or you are able to detect a viral load from your patient, you need to act on it. Really, that is the message. Don't get used to patients roaming around with detectable, viral loads. If the viral load is more than 1,000, it becomes a bit urgent that we need to act on it. If it's between 50 and 1,000, we need to monitor, do the repeats, and we need to decide at some point whether we are dealing with just a transient, temporary high viral load, or this is a significant a viral load that we need to deal with, right? So if you measure a viral load, you must act, you must respond to it. You need to ensure that your patient is assessed using the ABCDE adherence. Is your patient taking the drugs? Are they having social issues? Do they have new infections that need to be treated? Are they taking the drugs correctly, the correct dose? Do they have drug-drug interactions that we have missed? And is there an indication of a resistance, test? And once you have done your assessment, you need to implement interventions and repeat your viral load. So this is quite important. There's no point in regularly repeating viral loads if you are not responding and acting on your findings when you assess our patients. And this is the algorithm really from our guidelines. Firstly, we require that all patients who are taking ARVs should be monitored closely. A viral load should be done at 6 months, then at 12 months, and then once a year from there. If it is suppressed, we are happy. We celebrate with our patient. We buy them a cake. If the viral load is more than 1,000 copies, you have to do a thorough assessment. This is part of what we call enhanced adherence counseling. A meaning, is your patient taking the drugs as prescribed? Are they experiencing some infections that can, give you some rise in the viral load? Are they taking the drugs correctly? Drug interactions. Is there an indication for resistance, especially if they have a high viral load taking second-line drugs? Whatever you find, you need to address with the patient. You need to spend time with your patient, implementing interventions for the next 3 months, seeing your patient regularly, ensuring that they have support at home, and then repeat the viral load in 3 months' time. Then you can start to decide whether your patient, is in trouble or if you need to be doing other things. So an elevated viral load in the HIV context, it's an urgent matter. We don't want patients continuing to take drugs when the viral load is refusing to be suppressed, because they will accumulate more and more mutations, and that is something that we do not want. So having seen Josh, he's taking an efavirenz-based regimen. His viral load is now 10,000 copies. And following our discussion, what is your plan? So what are some of the things that you might want to do? You may select more than one if you think more than one things need to do. If a patient presents to you tomorrow and they've been on ARVs for a year and the viral load is more than 1,000 copies, or it's 10,000, as is the case here, what will you do for your patient there? All right, 5 more seconds, and then we will have to stop this poll. Yeah, thank you guys for participating. You are also encouraging me to continue, so that is quite good. I'm going to stop, unfortunately. Please forgive me, we can't keep the questions longer than this. Yes, so I see that most of you said, let's do enhanced adherence counseling. Yes, I fully agree with you that we have one high viral load. He reports missing doses. So that is part of your plan. Provide enhanced adherence counseling. Number 2, the current regimen, and you can see there, 53% of you said, let's also continue. So you are not planning to switch anything, and then let's repeat the viral load in 3 months. So that is your approach, those three. I see there's a small population who are saying switch efavirenz to DTG, right? Remember the golden rule of HIV medicine: never switch a single drug when your patient has a detectable viral load, or when you suspect that your patient is failing treatment, right? So this is quite important to remember. And prescribing a new second line, not yet, because remember, at this point, we cannot confirm that he is failing because we only have one high viral load. To switch to second line, we need a confirmation of 2 consecutive viral loads taken 3 months apart to then consider that our patient requires a new and better regimen. So thanks for your participation. Again, here's a nice table. You know, it says if your patient is suppressed, congratulate them, you know, provide incentives, support them, ensure that they remain suppressed. If the viral load is above 50 but less than 1,000, our guideline says repeat in 3 months. We will deal with this group here again, you know, with that particular topic of low-level viremia. And then if your viral load is above 1,000, which is our case, in our case scenario, our viral load is 10,000, and our patient is taking efavirenz as part of the regimen, you provide enhanced adherence counseling, you repeat the viral load in 3 months, and then you also check hepatitis B and an HB. You know, so this is where we are. We do not have the second viral load to look at. We will discuss in the next few weeks how to approach patients failing a DTG or a PI-based regimen, which is outside of the scope in terms of what we are trying to achieve today. So what are some of the causes of resistance? So remember, it's not always the patient. Some patients are very adherent and they tell you, I have never missed, I use condoms, I have one sexual partner, you know, whatever they tell you. So always assess, you know, maybe it's a viral factor. Maybe they've been infected earlier on with a very bad bug. Maybe the sexual partner has a very bad bug, or the virus just mutated because it's a virus that likes mutating anyway, especially in what we call HIV reservoirs, where sometimes ARVs find it very difficult to penetrate and to reach, like in your lymph nodes, your thymus, your spleen, you know, the blood-brain barrier, where the drugs might not penetrate, but the virus is there, you know. So you might still have a compartmentalization where the virus is in a specific compartment, and it is only exposed to low levels of drugs, you know. So there's drug factors, whether the regimen we are giving is the best. Remember my opening slides, I was trying to show you that in South Africa, if a patient is taking an efavirenz-based to drug interactions, you know, which may impact the blood levels for our patients. So that is quite key right there. So yes, I hope you are still with me. You know, we are experiencing a lot of what you call Vodacom and Escom and network issues, but I hope that you are coping. I'll be looking at today. I want to finish earlier so that we can have enough time to go through, you know, some of your questions, especially from last week as well. So yeah, so let's continue. We have some load shedding where I am, but I think I made plans so that we are not disturbed. So remember, if someone presents with a high viral load, right, a virus that's replicating, you have to assess, am I dealing with drug interactions? Is Josh having poor absorptions? Are the drugs metabolized quicker than they should? Does he have certain genetic predisposition which could make him more susceptible, you know, to resistance? Is he taking the drugs correctly? Have we given him the best regimen that we can give? Is he experiencing some social issues? Does he have support? You know, is he experiencing drug toxicity? All these things ultimately contribute to insufficient drug levels, allowing the virus to replicate in the presence of the drugs. You then get specific mutations, which we discussed yesterday, your KY103N, K65R, M184V, which would render our current regimen to be less effective. Sometimes the patient does not have any of these, but unfortunately they are exposed to someone who is treatment experienced and already having a resistant bug. So that is quite important right there. So when I said A, B, C, D, E, what am I talking about? So A, it's adherence. Josh, are you experiencing any side effects? You then assess his mental health state, whether he's able to cope with the information that you are giving him, he's able to care for himself, or does he need additional support and treatments? Is he being abused by substances? Does he stay in a poor support structure because of non-disclosure? And then other things, maybe he's taking other drugs. It's just too many things. So we need to assess that. We need to check for infections. Also checking for drug interactions and whether he's taking the drugs correctly, and then if resistance testing is indicated. But like I said, if a patient is failing an NNRTI-based regimen, there is no indication for resistance, right? For resistance testing. So enhanced adherence counseling is the mainstay of ensuring that we are able to pick up patients who are at risk of treatment failure, and we are able to provide adequate support. You are supposed to do it with an open mind. You need to make sure as a health worker that your patient sees you as a very supportive person who is non-judgmental, without stigmatizing the patient, right? You need to help the patient to understand the importance of taking his treatment and ensuring that the viral load ultimately is suppressed. Very, very important. A clinical assessment must be done, as well as a mental health assessment to understand, what might be going on. We need to understand all the barriers. I always talk about social scripts, that we prescribe drugs too much. When last did you prescribe a grant, a food parcel? When did you refer your patient to get an ID or to have a bank account or to a skills development program? Because if we are not dealing with these social barriers, we won't win. Health goes beyond the virus itself. It also includes the social, psychological stability and the emotional wellness of our patients. And if we undermine the impact of people's homes, the stability of families, whether people have livelihoods, employed, unemployed, hunger, if you undermine those things, there is no health program that can work. So we have to make sure that we've got partnerships with social structures to help those who might be addicted to alcohol and other bad substances. And at the end of the day, there has to be a plan that you develop with your patient, which is going to be implemented for the next 3 months, which includes regular visit, adherence support, SMS reminders, alarms, getting someone at home to come and support your patient, to be a treatment buddy during this period, and helping your patient to deal with all other barriers that they might have. So that when you repeat that 3 months viral load, that we really tried to implement improvements, So this is quite important. And then on that last poll, some people said, no, because dolutegravir is a very good drug and the patient has a higher viral load, let's just switch efavirenz to DTG. You are breaking a very key principle, right? And here's the principle: never change one drug in a failing regimen. Never violate this principle. I was mentored and trained with this thing, such that I just know it, that you shouldn't be doing it, because when you introduce one drug into a failing regimen, you are actually just giving your patient monotherapy, and they will fail that particular drug as well. If a patient is failing treatment, they don't need a single drug switch. They need a new regimen. In this instance, it will be our second line ART regimen, right? So very important that if the viral load is suppressed and you want to do a single drug substitution, yes, that is the right time. I always say, if your patient is suppressed, you can play with the drugs, right? But please don't play with the drugs when your patient has some high viral load, because with a high viral load, you are going to complicate future options for your patient, which is quite important. So Josh is back. So you did our adherence counseling, you supported him. Remember, he had a viral load of 10,000 copies. You remember that? He had a viral load of 10,000 copies. We did 3 months adherence support. Now he's back for the 3 months as you had instructed him. He tells you that I've been taking my drugs. I've never missed any doses. I'm not taking any other things. I'm not abused by substances, and he's of a sound mind. You repeat the 3 months viral load, and it's 8,580 copies. His hepatitis B status is negative. His HB is 12. So what is your plan at this point in time? What do you want to do? At this point in time, what do you want to do? So here are some options I've shared with you. Yeah. You may, am I correct? Yes, you may choose more than one option. Yeah, okay. Interesting. 10 more seconds. Let's all participate. Yes. 5 more, 3 more seconds. All right, I'm going to stop. If you haven't voted, my sincerest, apologies. So yes, this is how you opted. Interesting. Some of you are saying he has improved. Let's continue. Hey. Let me tell you something. I always tell people when they call for advice. I say, the virus will play with you for 10 years. Ne? It will keep on saying 7,000, 8,000, 6,000, that's what the virus does. That's the reason why you have people with high viral loads for 10 years being monitored, because we have so much hope that Shem, he's such a good patient, he will suppress. Remember what I said when we started? I said 96% of patients who are taking an efavirenz-based regimen, when they present with a high viral load, 96% of them have already developed mutations. And I've never heard of a situation where these mutations disappear. They can only be archived or hidden, but they are always there. So if a patient has developed mutations, there's no overuse of a condom, the kind of things we tell patients that will reverse the mutation, right? So don't be trapped by the virus. Very, very key. Adherence support, you always, you can never go wrong with adherence support. We can never say never. I think he has failed. I believe that Josh has failed treatment. Why am I saying so? What is the definition of treatment failure in a non-pregnant adult? 2 consecutive viral loads taken 3 months apart on a patient who has taken ARVs for more than 6 months. The first viral load was 10,000. Is it below 1,000 or above? It's above 1,000. The second viral load, is it below? It's above 1,000. Josh has failed. Josh has failed ARVs. Don't be tricked by the drop, 2,000. And remember, in non-pregnant adults, we don't use logs. We don't compare logs. Logs, we use them in PMTCT because in the pregnancy program, we give patients 30 days to resuppress, right? Here, he had enough time. If you do effective adherence for 3 months, we expect full suppression after 3 months. If the patient is not suppressing, they have failed treatment and they need a better regimen. Please don't keep them on a failing regimen, right? So most likely here, I would have said, continue to do adherence support and counseling and start to think about a second-line ART regimen for our patient, Josh. Don't be tricked by the drop there, right? So after 3 months, remember we had a viral load of 10,000. Now we are repeating the 3 months viral load, which is where we are, and it came back as 8,000. 8,000 is more than 1,000, right? And George is taking an efavirenz-based regimen. Therefore, the guidelines, this is from the guidelines, they say consider switching to second line if virological failure is confirmed. And what is the confirmation? 2 consecutive viral loads taken 3. He has failed. He has failed. You know, he has failed. He's unlikely to resuppress. Actually, these kinds of patients will not resuppress. The virus will just play games right there, right? So if the viral load came back less than 50, yes, we could be happier. If it's between 50 and 1,000, we would be more confused about what to do. But this one is a straight, clear process. If he was taking DTG or a PI, we would have to wait for 2 years and repeat viral loads. This block here, we are not going to discuss today. We are going to discuss it next week and the week after. So we are not going. But in terms of Josh, he has failed. 2 viral loads taken 3 months apart on an efavirenz-based regimen. Our patient has failed. So don't delay. You can see there, if adherence is addressed, don't delay the switch because it's taking an NNRTI. It's a weak regimen. It's got a low barrier to resistance. If the patient continues to take drugs and the virus replicates in the presence of these drugs, the patient has failed. So that is quite key, right? Now, principles when considering virological failure. Eligibility to second line ART is determined by a number of things. One, the viral load. So in our instance, the patient has met the definition or the requirement for treatment failure. 2 consecutive viral loads are more than 1,000, right? The current regimen, it's a weakling regimen with efavirenz, so we have no worries, and we don't want to delay. We are going to switch. And then time on the regimen, only if he was taking a DTG or a PI-based regimen would be assessing the time. But remember, even for efavirenz, we can't talk treatment failure if the patient has taken ARVs for less than 6 months. So this is quite important. So since we are agreeing, I hope you are agreeing with me that he needs to be switched, he needs a better regimen. What would be an ideal regimen for Brother Josh? Right. Tell me, yeah. He's taking tenofovir, lamivudine, and efavirenz. Yes. Go for gold. 5 more seconds. 5 more seconds. I hope you guys are still with me. You are engaged in the dark with ESCOM. All right, I'm going to stop and then show you the results. Now, this is the mistake we do, isn't it? You look at that first regimen there, TLD. Remember, he's taking tenofovir already. He's taking lamivudine already, and he has failed. If you give him that first regimen, you are giving monotherapy. You are just giving DTG on its own. And DTG has a weakness, which we will discuss in the next 2 weeks. It has a weakness in that it works best when the NRTI backbone is still very active. So you don't want to be giving DTG where tenofovir is compromised. So that first regimen is fully out and it's risky, and your patient will ultimately fail DTG if we are not careful, right? Then the second regimen, probably a preferred one, zidovudine, lamivudine with DTG. So probably the best option, zidovudine, lamivudine, lopinavir, ritonavir. Not a bad regimen, but we will discuss now as to under what context would you consider DTG versus lopinavir in this context, right? And then that last one, yeah, there's nothing wrong with it because lopinavir is a very a good drug. It can cope with a weak NRTI backbone. However, in terms of the pill burden, most likely the second regimen there is what we are trying to get to. And it's good to be not sure so that you can ask us via WhatsApp and call us and we're able to help you, you know. So not being sure is a very good skill a clinician needs to have. So this is our treatment approach for both first and second line. Always your regimen should have 2 NRTIs and a choice between an integrase inhibitor and an NRTI and a PI. If you look at our case scenario, he was taking tenofovir with lamivudine, actually with emtricitabine, right? And efavirenz, but it doesn't matter. So he was taking TEE there, TEE, that's what he was taking. If you fail tenofovir because of a high viral load, you automatically fail abacavir, right? K65R, that mutation which we discussed last week, would render these 2 drugs less effective. Therefore, if you fail tenofovir or abacavir, your next drug is zidovudine, right? If you fail efavirenz, you have 2 options, either dolutegravir or lopinavir, ritonavir, depending on certain issues that you might have with your patient. So here we are. He was taking tenofovir, emtricitabine, efavirenz. We are stopping this regimen and we are going to give zidovudine, lamivudine, and a choice between DTG or a PI regimen. And that is determined by some history and whatever else your patient is exposed to. Right, so he's taking an efavirenz-based regimen, and he's taking, and then we want to transition him first to DTG, but we need to make sure that DTG is safe. So you want to assess for drug-drug interactions, you know, anticonvulsants. If he's diabetic, taking more than 1,000 milligrams of metformin, you might not want to give DTG. You know, if he's taking a lot of supplements, you know, calcium, iron, those are not absolute contraindications, but you need to ensure that you discuss the timing of taking, you know, your antacids, your what you call your magnesiums, aluminiums, calcium, iron, you know, other vitamins. So you have to know what is the story really with your patient right there, right? And then some patients then might need to get lopinavir, ritonavir, or even atazanavir, ritonavir, depending on the history they have. And also remember, if you are transitioning a patient from first line to second line, there's no need for a resistance test. Even when a patient fails DTG later on and we need to transition them to lopinavir, there's no need for resistance testing. We'll discuss this later as well, that resistance testing for DTG is only indicated if DTG is taken as part of second line. So quite important at that point in time. So coming back, in terms of treatment failure for today, we are focusing on a patient who's failing a first line regimen, particularly an NNRTI regimen. You can see George was taking tenofovir, lamivudine, and efavirenz, or emtricitabine and efavirenz. He has failed based on 2 viral loads. There is no need to do a resistance test, as you can see right there. But we have to check the hepatitis B status of our patient. And remember, it was documented as negative, right? So we stop tenofovir, we provide zidovudine, we continue lamivudine there, right? We stop efavirenz and we give DTG, right? Where there's contraindications to dolutegravir, we can then opt for lopinavir, ritonavir. So that is where we are right there, right? And in the context of a positive hepatitis B status, right, is the same. Remember, we give zidovudine, lamivudine, DTG. So zidovudine, lamivudine, DTG, but we are unable to interrupt tenofovir right there, right? We are unable to provide, to stop tenofovir, because both tenofovir and lamivudine, those 2 there, would be effective against both HIV and hepatitis B. So our patient will take 4 drugs right there: zidovudine, tenofovir, lamivudine, and dolutegravir. Now, to see the power of lopinavir, ritonavir, you would see that in the context of hepatitis B, you can treat your patient with 3 drugs: tenofovir, lamivudine, and lopinavir. Tenofovir and lamivudine would still control hepatitis B, and these 3 drugs, tenofovir, lamivudine, and lopinavir, would still effectively control HIV. Why 3 drugs here and why 4 drugs there? It's because lopinavir is a very potent drug. It can handle a weak NRTI backbone such that you don't need to add a 4th drug. DTG can handle a weak NRTI backbone. Therefore, we must continue to add a 4th drug so that at least we have 1 active NRTI in that regimen, right? I hope you are with me. Now, can you type in the chat box there? Tell me, if you had a patient who had hepatitis B positive and they were failing first line and they needed second line regimen, TDF, zidovudine, lamivudine, DTG, how many tablets would you how many tablets would your patient take? How many tablets per day would your patient take? Can you type for me there? How many tablets would your patient take if they have hepatitis B and HIV and they need the second line? I see Faiza Pile, say 3, 2, you table say 6. 2 tablets. Can you explain your answer? Why 2? Why 3? Why 4? Can someone tell me? Night 4. You guys are too fast. You are so fast. Okay, Dr. Bajava. Anyway, I always talk about it. I think if you have heard me talking about the use of fixed dose combinations to enhance adherence, that is the trick right there, right? And I see some of you got it right there. Good. So it's at the most. So, you know, a person who does not understand that when you prescribe, you should also enhance adherence through your prescribing habits, right? You would be prescribing these drugs 1-1-1-1 and creating a lot of problems. So this patient, yes, it's a lot of drugs in terms of your eyes and what you're looking at. But if you use fixed dose combination, you can give TLD. Do you see? TLD, so tenofovir, lamivudine, dolutegravir, as a fixed dose combination, 1 tablet once daily, plus zidovudine 300 milligrams BD. So your patient will take 3 tablets in 24 hours, right? 3 tablets. In the morning, he takes zidovudine with TLD 1-1, at night, zidovudine alone. So you see how the importance of embracing, Cynthia Gamma, you got it there. You know, the importance of embracing fixed dose combination, very, 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 very key. So second line regimen, zidovudine is prescribed as 300 milligrams BD per os, and you need to monitor for the HB, right? Take it with lamivudine, 300 milligrams daily, right? And then dolutegravir, 50 milligrams daily, right there. So that will be your standard. Where DTG is contraindicated for whatever reason, your option is to then use lopinavir, ritonavir, 400 over 100 milligrams, and you need to do your lipid profile. Is it 3 months? Yes, after taking, once your patient has taken the drug for 3 months, right? So these are your fixed dose combinations. So, you know, for zidovudine, lamivudine, and dolutegravir, you still use fixed dose combinations. So you use your Combivir or your Lamzid there, which is 1 tablet that has AZT and lamivudine. Your patient will still need to take this twice a day, and then with your single dolutegravir. So it's still 3 tablets, right? If your patient has hepatitis B and you can't stop TDF, so you still give TLD there, 1 tablet that has 3 drugs that you need, then you add your zidovudine 50 milligrams. It's still 3 drugs, you see. So fix those combinations in his enhance adherence, and they give us fewer side effects, and they are really cost effective. And yes, Mary Adams, Augusta, use fix those combinations, you know, and then the questions we will deal with shortly. I think I will give you enough time today, I promise, because I'm about to finish in the next 10 slides. Just to highlight a few important things as well. Remember, dolutegravir can still be used as well as part of second line, as long as your patient is suppressed. Very important. Your patient must be suppressed on second line and must be taking a standard second line ART regimen, right? If your patient is taking a regimen like tenofovir, emtricitabine, lopinavir, ritonavir, please avoid, don't switch, don't play. And I had a call again from Amajuba this week of a pregnant lady, mental health user. She was 34 weeks pregnant, and it was a very complex case, I can tell you, around some of these regimens. So whenever you do a single drug switch, the viral load must be suppressed, but you need to make sure that your patient, before you give DTG, you have a strong NRTI backbone. If you are not sure, if you are not confident that your NRTIs are still active, please leave those patients on lopinavir or initiate them on lopinavir. Lopinavir can handle a weak regimen. DTG might not be able to do that, right? I explained the issue of hepatitis B, HIV co-infection to say on our first line standard regimen, TLD, we also have two drugs, the ones in red there, tenofovir and lamivudine, which are also active against hepatitis B. So this is quite important. So when your patient fails first line and they need second line drugs, as you can see there, you need to check your hepatitis B status, because if your patient has hepatitis B, this regimen, yes, it will control HIV, but it might be weak for hepatitis B, because now you'll have monotherapy for hepatitis B. Rather, you prescribe it, tenofovir, lamivudine, DTG, or lopinavir, and then also prescribe TDF so that your patient takes 4 drugs, right? AZT, lamivudine, DTG for HIV, TDF, lamivudine for hepatitis B. Never interrupt TDF and lamivudine in a patient who's got both HIV and hepatitis B. So that is, yes, that is the message there. Now, tell me something which I generally get a question about. After you switch someone to second line, when do you, what is your follow-up plan? When do you repeat the viral load? So when do we repeat viral loads after switching? I know it's always an argument. I just think there's no, okay, it depends on what you guys are going to choose. But between the competing options, I think, it just depends. But I'll tell you what the guidelines say, and I'll tell you what my own, not only my own, I've seen it also in some of the private sector guidelines, how they approach. So he was initiated on zidovudine, lamivudine, and DTG, as you can see. When do you repeat? Because don't just switch and forget. I mean, this is another issue we see where patients are switched, but after that, it's like we think they're okay. No, you have to do your follow-up. So I see most of you are saying 3 months, and then others say 6 months. So if you follow the public sector guidelines, really, it's 6 months. If 3 months is a good time. For me as well, I really like 3 months because I expect everyone to be suppressed, especially on DTG. At 3 months, they should be suppressed. But let me show you what the guideline table looks like in terms of monitoring. So you would see that once you switch your patient to second line, remember there we are asking about the viral load. You are not going to see the patient after 6 months, right? You will probably see this patient monthly for the first 3 months, and then probably at 6 months and so on. So because we have prescribed AZT, we need to check their HB during the switch, making sure that it's okay, then repeat it at 3 months, 6 months, and 12 months, and then once a year from that. Hepatitis B we checked, which was negative. If we had started the patient on lopinavir, ritonavir, we'd be doing a fasting cholesterol at 3 months on lopinavir, ritonavir. The viral load, this was the question. In terms of our guidelines, it's 6 months, right? After switch, you repeat the viral load at 6 months. But like I'm saying, I like the whole 3 months thing, and some private sector guidelines also refer to that 3 months. So clinically as well, assess your patient, whether your patient is gaining weight, improving, do the 7 days review to check your HB results, and then the monthly during the first 3 months, and then after that 6 months, 12 months, and then we take it from there. Makai, yes, you must be a midwife or a doctor with a special interest in obstetrics. For today, we are dealing with non-pregnant adults. So I'm with you right there, and you are on point that if okay, Josh is a male, but if Josh was pregnant, we will repeat the viral load in 3 months' time. All right. Just to give you highlights, and I've asked our colleagues, Abvi, to bring us a pediatrician next month, I hope, who will then take us through issues of children and treatment failure. I know it's going to be very exciting, but just remember, for children, the second line regimen is not standard. There's no standard second line regimen. It is always determined by the regimen that the child is taking at the time when they fail. And it is very complex, because you could see that most kids are going to be taking lopinavir, and then if someone has a high viral load on lopinavir, ritonavir, there's a whole lot of additional processes we need to do for us to confirm if there's treatment failure, even with DTG. So with children, it's a bit complex, but please remember that certain drugs can only be used at certain weights or even ages. For example, lopinavir can only be used once the child is older than 1 month and the weight is more than 3 kgs. DTG can only be used if the weight is above 20 kgs. Tenofovir can only be used if the weight is above 35 kgs and the child is older than 10 years. So even go second line, when we discuss now the second line, you should always remember these age cutoffs, because some drugs like abacavir, you can't use it if the child is less than 1 month. And then this is a 4-week transition regimen. So there's no child who's going to fail this regimen, because as soon as they grow to 4 weeks, we transition them irrespective of the viral loads that they take. That's why you would see that if you have a child who's failing an efavirenz-based regimen, you need to check their age and weight, right? If the weight is below 20 kgs, the next transition will be to lopinavir, ritonavir, because you can't use dolutegravir for now if the weight is below 20 kgs, right? If the weight is above 20 kgs, DTG is considered. Some kids are going to have a high viral load on DTG and therefore can be transitioned to a lopinavir-based regimen. I tell you, with children, generally, we need to do a resistance test because most of them are on a lopinavir or a DTG-based regimen. We still have kids who are taking efavirenz. Remember, efavirenz in children can only be used if the weight of the child is above 10 kgs and they are older than 3 years. So those are the things with kids. With kids, remember, your second line regimen determined by the weight bands. So if this child was taking abacavir, lamivudine with efavirenz for argument's sake, and they are failing, you would check their weight. If their weight is less than 20 kgs, you would then give them zidovudine with lamivudine and lopinavir because the child was taking abacavir. But if the child was taking zidovudine, you could use abacavir on second line. So with children, it's probably a topic on its own. The only thing, my key message to you is always remember, children tend to take more complex regimens with drugs that have a high barrier to resistance that are unlikely to be failed. Always check the child's age and weight in determining what is your next move. And I tell you, the key advice is to always call an expert when you have a child failing. Call someone, even if he's not an expert, but 2 heads are better than 1, and then you'll be able to come to some conclusion around how to handle these cases. At the end of the day, managing a high viral load, you have to find the cause. Why is my patient having a high viral load? Deal with the issue. A viral load is a symptom. It's a fruit of poor adherence, drug-drug interaction, infections, and with with children also, they rely on a secondary person to give them. So it can be quite complex when you involve the social issues. Then always repeat your viral load. If you have 2 consecutive viral loads taken 3 months apart in a non-pregnant adult, consider second line if appropriate, and don't just switch and disappear. Please monitor our patients very closely after that. Remember, a high viral load is associated with a declining immunological function. Later on, your patient presents with AIDS-defining conditions, and we really don't want that. It becomes a very costly exercise. And also the regimen, second line, third line are very complex, big tablets, more side effects. So it's not something that we really like. And if you don't switch, it's people lose their loved ones, they end up admitted, patients accumulate more and more mutations, and the second line, third line drugs are compromised. You find that it's a very salvage therapy with a lot of drugs and side effects. And then ultimately, that's why we have circulating mutations in South Africa, because we leave people too long on failing regimens, and they spread these particular bad viruses to the next person. All right. So I hope this session was really worth your time, and that you have managed, to grasp something. But importantly, I would like to see you drawing those viral loads, those files, doing audits, calling back your patients from tomorrow, evaluating those patients, and then deciding which ones are ready to be switched. That would really make it exciting for me. So I don't know. I see Kwasi, Esther, and Sigoko, Zwibuleni, your hands are up. Can you lower your hands if that is a mistake? If Vele you want to make a comment, I'm going to allow you to talk. You and other people as well. If you have a specific question you would like to raise via the mic, please feel free to raise your hand, and then I will give you a chance. Esther, can we start with you? You may unmute your mic. Do you have a question, says Esther? Okay, you have lowered your hand. Zwibuleni, do you have a comment or a question? Zwibuleni? All right, seems like not. You may unmute. Kwasi, you may unmute. Okay, I'm going to give the new hands time to talk. It was Esther. Yes, Esther. You may unmute. Yes, Esther. Esther Motankisi. Are you able to unmute, says Esther? All right. Okay, Zamukuhle, are you able to unmute? Zamukuhle Koti? Please unmute your mic. Yes, I can hear you.
Yes, I just want to know the viral load. How many times must you repeat if it's above 1,000? How many times must you if the client is failing?
Okay, it's failing which drugs? Which drugs?
It's failing AZT, 3T, and Lopinavir.
Oh, okay. Yes. I don't want to answer that, Zamukuhle. I need you to join next week when we discuss patients who have a high viral load on a protease inhibitor. But at a high level, you need a minimum of 3 viral loads that are more than 1,000 taken over a course of 2 years if a patient is taking lopinavir, ritonavir. But I don't want to go into detail on it. I want us to have a proper discussion when the time comes next week, Thursday. Thank you. I appreciate your question. Let's take our last hand, Sipo.
Okay.
Sipo, are you able to unmute? What happened? Okay, Sipo has lowered his hand. All right. Faiza Pillay, do you want to talk? I want to give you talking rights. I just want to hear one more question from someone. Yes, where's Faiza?
Good
Yes,
evening. Thank you for the talk. I
yes,
just
ma'am.
wanted to check patient that was on TE failing, same with liver failure, secondary to hepatitis B, needing to restart. Obviously, you add the TDF, but is the dolutegravir safe in that situation?
Yeah, so you are asking a very complex scenario. I need to do that particular presentation on drug-induced liver injury and how you approach the scenarios, because what you would have to do, it depends on how bad the liver toxicity is. Sometimes we want to give the liver a cooling off period before we resume ARV drugs. But if I was to say to you, if a patient has an efavirenz associated liver injury and the patient has hepatitis B as well, so I would keep tenofovir, lamivudine in that regimen. When I reinitiate the patient, I would give that DTG has less liver toxicity, than most of the drugs that we are using currently. So remember, almost all ARV drugs can cause some level of liver injury, whether through mitochondrial toxicity by your NRTIs, where the liver cells become filled with fat, hepatosteatosis. If you look at atazanavir, it can give you asymptomatic high bilirubinemia. And nevirapine obviously being the culprit of them all. So all drugs, to a certain extent, may cause liver injury, but by different mechanisms. But DTG would be regarded as a safer option in that context. But we must discuss it case by case, depending on how your patient is presenting and what is best for that patient. Yeah. Okay, quite complex, Faiza. And then I want to ask, is it Dr. Chibangu? I might be correct. Yes. Chibanko Pierre.
Yes.
Ashama,
You
yes,
can hear
yes.
me?
Loud and clear. Thank you.
Thank you, Doc. It was a lovely session. Unfortunately, I'm working in obstetrics and gynecology.
Okay.
I would like to know, when is the session for PMTCT? That's
Yes. Thank you. Thank you for that question. I think once we have dealt, if I remember, Amanda will remind me as well. Once we have dealt with PI, treatment failure, and DTG, the next topic is a high viral load in pregnancy. So it's coming, I think it's going to be our third or fourth session from today. So it's already scheduled. So yes.
and sorry, Doc, and I
yes.
understood. Thank you very much. And are we gonna get a link to all the sessions?
Yes, you will. I will add you, but also visit our website and register for our emailing system or even as a member. But we will send you emails directly. We will use your registration from today to add to the database. Then you'll get our invitations directly. Yeah.
You are saving lives, I can tell you. Thank you very much. It was lovely for giving us this knowledge. Thank you very much.
Thank you. It's quite appreciated. I appreciate the feedback. All right, colleagues, I see there's a lot of questions, so we still have some time. Remember, we said we are here until past. So let's try to do the Q&A first. Jabulani, you are saying I need clarity on the difference between immune non-responders and immunological failure. Okay, two things, Jabulani. When we talk about immunological failure, we are talking about someone who is infected, who is on ARVs, and that patient is not improving. The CD4 count is not improving, or it has dropped below the pre-treatment level. So that is immunological failure. When you talk about an immune non-responder, right, we are talking about a patient who is infected, right, but they are called non-responders because they are able to control the virus without treatment, right? So they maintain a high CD4 count, usually close to 1,000, you know, and they maintain viral loads below 1,000 copies because their immune system, for many reasons, I mean, there's a lot of studies being done about this group of patients to try and determine what's unique about them. And they can stay like that for even up to 20 years without taking ARVs. So they are called non-responders in that context, right? But I'm not sure if you need further clarity on that question, you may type in. Later, you are saying, do we have to switch a patient if they're not compliant, if 2 consecutive viral loads are above 1,000? So later, yes, switching does not address adherence, right? So if there's social issues that need to be addressed, we need to give those issues time to be addressed. But it doesn't mean that the patient will resuppress, because like I said, if they are on a NNRTI regimen and you have 2 viral loads more than 1,000, that means they have failed to resuppress. They have already developed mutations, and you cannot reverse these mutations, right? They can be archived to appear later if at the time when we are testing for those mutations, the patient is not taking those drugs, but you can't reverse these mutations. So it's quite important that let's deal with social issues so that we do not put the new regimen at risk of treatment failure. Damali, Laira, what about the Nadia research? Yes, I know about all these studies, and there's a lot of conflicting, and maybe you have a specific question that you want us to address around the study. You may, say what specific issues. But as things stand, DTG, we have to really consider using it with an active NRTI. I know these are conflicting issues between guidelines and studies, and we might, just for now, yeah? Is it possible for a 3-year-old child to swallow a tablet, or do we need to make a plan on efavirenz? Akona, efavirenz at that age, we have capsules that you can open. You can open the capsule and so we don't use the hard tablets at that age. Jackie, you seem to be happy. Lamula, Nyana, you are saying, can patients be switched to 3TC, TDF, and DTG if they fail efavirenz? I think I've addressed that. The answer is no. You need a new NRTI. So TDF has to be replaced with AZT for those groups of patients. Esther, you are asking, hi doctor, can you give info on TB? Not really for today, but TB, the issue is drug-drug interactions. Rifampicin is a liver enzyme inducer, so it might affect the bioavailability of some ARV drugs, including dolutegravir, lopinavir, ritonavir, and nevirapine. So nevirapine should not be given with TB treatment. Dolutegravir, you need to increase the dose to 50 milligrams, 12 hourly. And then your lopinavir, ritonavir, you need to super boost it by prescribing additional ritonavir or even doubling the dose. So I'm hoping next week I'll add a case that has these drug-drug interactions. Then we can go into this in a little bit more detail. I want to check the chat because I see, yay, you are, yeah, I'm sorry that we are struggling with network. It's the, what you call, it's our electricity issues in South Africa. Yes, lastly, Welipa, the issue of patients with viral loads between 50 and 1,000, I can't reduce it to a sentence. So I think it's the third session. So we have PI-based DTG, then we've got low-level viremia, then we have pregnancy as a fourth session. So be patient. Let's deal with it in the third masterclass from today. Kunjiwa, you are saying, in case a patient is taking TEE and fail the regimen and the doctor switches to TLD, yeah, yeah, so the patient might suppress. We know that there's also now the whole thing around treating HIV with 2 drugs, you know, but this is still at research level and not necessarily at the practical level, you know. So for now, let's follow things. And one patient will suppress, the next patient doesn't suppress. And that is where science comes in. Science helps us to make decisions that will help us to do the right thing for all patients or the majority of patients. We don't want clinical decisions where something works for this one, doesn't work for this one. So the best thing when someone fails TEE is to give them ALD, zidovudine, lamivudine with dolutegravir. That is that. But remember, check drug-drug interactions against your dolutegravir. Are we going to get presentations and certificates? Become a member and support us. But yes, you will get. You know, we are good people, but please become a member and support us. Yes, you will get CPD points and certificates. I see IMCI, we will work on it. There's a lot to cover on HIV here. PMTCT coming soon, yes. If a patient was put on second line with Alluvia due to side effects of efavirenz, is it possible to replace Alluvia with DTG? I addressed this one. I said if a patient is taking lopinavir, ritonavir as part of first line and they are suppressed, you may transition them to DTG, right? But you need to check the drug history of that patient. If the patient has previously failed your NRTIs, TDF, or abacavir, you need to be very cautious of introducing DTG in that context. But like I'm saying, it's a contested issue. And in South Africa, our guidelines have not changed. So we require that DTG be used when a patient is taking a standard second-line regimen and the viral load is suppressed at that point in time. Yes, we will share the recording. We'll also put it on our YouTube channel. Why AK Desai, why do we find patients with high viral load but a high CD4 count? It means it's still coming down. The immune system is still fighting. Desai, I don't have an absolute answer. You know, CD4 counts are variable. They change at night. When you are stressed, you know, they go down and so on. But if the viral load is high, it tells you that your patient is failing treatment, right? Tebogo, you were proposing the regimen. Perfect, perfect. Tembela, you seem happy. Cool, 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 guys. Okay, here's a Doreen. Doctor, I've noticed our diabetic patients on 850 metformin when switched from TEE to TLD, the sugar is not controlled as we switch them to metformin. Yeah, and Lauren, I had a case this week. You know, I don't know if Sister Tipe is here. She called me. They had their primary healthcare doctor there and the clinic manager about the diabetic patient. The rule, you see, the rule is don't, so, and people do it this way. I don't know. It might be because you want to give TLD by all means. But the rule, and I want to emphasize it, the rule is, if you have a diabetic patient who's taking more than 1,000 milligrams of metformin, don't change the anti-diabetic treatment trying to fit in TLD. That is not the protocol. Give an alternate ART regimen which can be tolerated with those high doses of metformin. Because now what you have done here, you transitioned your patient to TLD, and you realize that the metformin is high. You have now lowered your dosage for your diabetic. Now your patient is uncontrolled. It's the same. Yeah, we don't do it that way. If I come to you today, I'm taking metformin 850 milligrams 12 hourly, right? All that tells you is that I'm probably not a candidate for dolutegravir. Give me TEE or give me something with lopinavir, ritonavir. You know, that is what. Don't try and make me an uncontrollable diabetic by forcing me to take dolutegravir. I hope, Glory, you get it, because it's another way of looking at it. Tebogo, you're saying a patient failing TEE, presenting with renal failure and anemia, how do I approach the second line regimen? Since the patient is failing TDF and should be or is also failing Abacave. So, Tebo, if you're listening, it's a very complex case, but I hope what I'm going to say will make sense to you. So the patient is taking tenofovir, emtricitabine, efavirenz. The patient has renal failure and then is also anemic. I know what you're trying to tell me. You're trying to tell me that zidovudine is not an option. Number one, zidovudine can still become an option for this patient. It depends on what is the cause for this anemia. If it's secondary, deal with the secondary cause and give your patient zidovudine as part of your second line. The other option for this patient is as follows. Remember I said you need to know now the drugs because we are dealing with complicated things these 2 weeks, right? I said to you, lopinavir, ritonavir can cope with a weak NRTI. Do you remember that sentence? In other words, you can treat a patient who needs second line with abacavir, lamivudine, and lopinavir, ritonavir, because lopinavir can deal with a weak abacavir regimen, but you cannot give DTG when your NRTI backbone is compromised. Remember, ideally, you would have wanted to stop TDF and give zidovudine. Now, zidovudine cannot be given because your patient has severe anemia. You are left with abacavir, but abacavir is already compromised because your patient has failed tenofovir. Now that your backbone is compromised, what is going to be your foundational drug to use? It's not DTG. For now, right? I know some will say, but the studies are changing. But for now, your foundational drug will be lopinavir, ritonavir, and your patient will do well. But like I say, these cases, we discuss them one-on-one so that we can take it right. We will stop exactly at past. We have 1 minute to go. So Mamu Jadibi, you are saying good evening, doctor and class. In case you have a child or the child is 5 weeks old and the weight is below 3 kg and the baby is out of what regimen of drugs can we give? Yeah, now this is the issue. Remember, when we say don't give abacavir and lopinavir, ritonavir to children who are less than 1 month, right? Or the weight is less than 3 kg, it is not about these values. It's about physiology. So even if the child might be 5 weeks old, it's likely that physiologically the child is not ready to metabolize this drug, right? Abacavir, they metabolize it very quickly. We don't even know the dose if the weight is below 3 kg. You won't find the dose, even if you go to the dosing chart. We don't know because they metabolize the drug very quickly. Lopinavir, ritonavir, it makes our kids to be sick. They present as if they've got septicemia, you know. So rather keep them on that transition regimen, which is zidovudine, lamivudine, and nevirapine. Help the child to gain weight, deal with breastfeeding and nutritional issues, treat infections. And then once the child is physiologically ready, they are older than 1 month, they are gaining weight, then you should be able to initiate your patient on an appropriate regimen. Colleagues, my session is going to stop here.